My hands don't look like my hands anymore.
Yeah, that is a genuinely unsettling opening line.
It really is. I
Yeah.
mean, there's no name, no diagnosis, just a scared patient, sitting at a triage desk, looking down at her own fingers and feeling like her body has just been replaced by a stranger's.
Yep.
Welcome to the deep dive, everyone.
Thank you. And, in rheumatology, this is actually exactly how the process starts.
Right.
You aren't handed a clean textbook diagnosis. You're handed this strange sentence, a totally subjective human experience of pain, and a highly complex puzzle to solve.
Exactly. And we're using this medical transcript today to explore a world that is, frankly, less like standard medicine and more like high-stakes detective work. Our goal today isn't just to tell you what diseases exist.
No, not at all.
We're going to build a diagnostic toolkit alongside you. We want to show you the underlying biology and the deductive reasoning that doctors use to solve these invisible medical mysteries. I mean, think of a rheumatologist like a detective arriving at a crime scene.
I like that analogy.
But the victim can't name the culprit, right? There are no witnesses, and the only clues left behind are swollen, aching joints.
Yeah, and it requires extreme precision to crack that kind of case. I mean, the clinician has to take that subjective fear, the feeling that your hands are foreign to you, and translate it into a rigorous objective framework.
Because sloppy terminology leads to misdiagnoses.
Exactly.
Which is why this matters to you listening. The next time you go to a doctor for, a weird ache, a mysterious pain in your knee, or a stiff finger that just won't bend, this conversation is going to reveal the rapid-fire, invisible math happening inside that doctor's head while they listen to you talk.
It's a lot of math, honestly.
Yeah, so we need to start with the power of precision. To solve the mystery of this woman's hands, we have to define our terms.
We really do, because in this field, precision completely alters the differential diagnosis. Let's look at the strict math of joint pain.
Okay, lay it on me.
When a patient says their joints hurt, the very first thing a rheumatologist does is count them.
Literally just count the joints.
Just count them. If more than 4 joints are involved, clinical consensus defines that as polyarthritis.
Okay, more than 4 is polyarthritis.
Right, and if it's between 2 and 4 joints, that is oligoarthritis. And if it's just one single joint, it's monoarthritis.
Okay, wait, I have to push back on this a little bit.
Sure.
If 4 joints hurt, it's one category. But if 5 joints hurt, it's an entirely different disease track. That sounds like, I don't know, arbitrary magic numbers. Why does the 5th joint magically change the biological reality of what's happening in the body?
I know it feels arbitrary when you just look at the raw numbers, but it's actually based on the statistical probability of systemic versus localized pathology.
Okay, unpack that for me.
So, if you have 1 or 2 swollen joints, the math suggests a localized issue. Maybe it's an infection in that specific joint, or localized crystal buildup, like gout.
Oh, right, gout.
Or even just isolated mechanical wear and tear. But once you hit 5 joints, the probability shifts massively.
Because it's too much of a coincidence.
Exactly. The immune system is likely mounting a systemic, coordinated cascade. These aren't just arbitrary labels. They sort patients into entirely different diagnostic universes.
Diagnostic universes, I love that term. So, let's say the doctor counts 3 swollen joints. Where does that put us?
Well, that puts you in the oligoarthritis universe, the 2 to 4 joint category.
Right.
So when a doctor counts 3 affected joints, they immediately start looking at the spondyloarthritis family of diseases, or SPA for short.
And what actually lives in that SPA universe?
Conditions like psoriatic arthritis, certain types of juvenile idiopathic arthritis, and Lofgren's syndrome.
Lofgren syndrome. What is that one?
It's actually a fascinating form of acute sarcoidosis. It's a systemic inflammatory disease that often starts with massive inflammation in the lungs and lymph nodes, but physically it manifests as severe arthritis, typically in the ankles.
Wow. So just by counting to 3 instead of 5, the doctor has effectively eliminated hundreds of systemic autoimmune diseases and zeroed in on this specific SPA family.
Correct. And clinical data shows there is a highly specific texture to this SPA-related oligoarthritis. It has a literal physical fingerprint.
What does that look like?
It tends to favor the lower half of the body more than the upper. It is almost always strikingly asymmetric.
Asymmetric meaning like one side but not the other.
Yeah, meaning your left knee might be swollen to the size of a grapefruit, but your right knee is perfectly fine.
Oh, wow.
And crucially, it heavily features enthesitis.
Enthesitis. Okay, let's break down the biology of that because it sounds like a major differentiator.
It really is. So arthritis, fundamentally, is inflammation inside the joint capsule itself. in the synovial fluid and the lining.
Right.
Enthesitis is different. It is inflammation specifically at the enthesis. That's the anatomical site where a tendon or ligament physically inserts into the bone.
So if we imagine if the bone is a concrete wall, right, and the tendon is a rope anchoring a ship to that wall, enthesitis means the fire is burning right at the anchor point on the wall where the tension is highest, rather than out in the middle of the rope or inside the ship itself.
That's a really helpful visualization, yeah. Though biologically, it's about the intersection of biomechanical stress and immune surveillance.
Okay.
The enthesis is an area under immense physical strain, and in SPA diseases, the immune system inappropriately targets that specific junction for inflammation.
So if a patient has pain in 3 joints, mostly in their legs, it's asymmetric, and their Achilles tendon insertion points are throbbing, the clinician is already mapping out the SPA universe before they even order a single blood test.
Exactly. It's incredible pattern recognition. But before a doctor can confidently say a patient has true polyarthritis, meaning more than 4 joints are inflamed, they have to make sure they aren't being tricked by something else entirely.
Ah, the imposters.
Yes, the imposters. Medical literature is full of them.
Right, conditions that mimic widespread joint inflammation but operate on completely different biological mechanisms.
Hmm.
So if someone comes in with aching joints everywhere and it's not actually arthritis, what else are we looking at?
Well, the clinician has to rule out several major categories. One of the classic imposters is polymyalgia rheumatica, or PMR.
PMR, okay.
Patients with PMR will tell you their joints ache terribly. But if you look at the mechanism, PMR is primarily causing inflammation in the proximal muscle groups and bursae.
Proximal meaning close to the center of the body.
Right, think the heavy shoulder and hip girdles. The pain radiates so severely that the patient perceives it as widespread joint pain, but the actual distal joints, like the hands and wrists, are usually entirely spared.
So the brain is just misinterpreting where the fire is actually burning.
Exactly. The signals are overwhelming. Another critical imposter is fibromyalgia.
Oh, I've heard of that.
Yeah, fibromyalgia produces profound, widespread pain that patients often describe as deep joint aching. But it is a disorder of central nervous system processing.
Meaning it's in the nerves, not the joints.
Right. The brain and spinal cord are essentially amplifying pain signals. There is no actual local tissue inflammation, swelling, or joint destruction occurring.
So treating a fibromyalgia patient with intense immunosuppressant drugs meant for severe arthritis wouldn't just be ineffective, it would actually expose them to massive unnecessary risks.
Precisely. Which is why these imposters must be systematically and respectfully ruled out.
Okay, so once you know it is definitively polyarthritis, the clinician relies on a rigid 5-question skeleton to crack the case. Yeah, right? Let's lay out the skeleton. What are the 5 questions that actually map the puzzle?
Okay, question 1. Is the condition acute or chronic? Question 2. Is it inflammatory or non-inflammatory?
Got it.
Question 3. What does the past, personal, and family history tell you? Question 4. What do the extra-articular features reveal?
Okay.
And finally, question 5. What is the exact topography or physical pattern of the joint involvement?
Let's unpack the logic behind those.
Uh-huh.
Question 2 really stands out to me. Inflammatory versus non-inflammatory. How do you even tell the difference without a microscope? I mean, pain is pain, right?
You actually look at the mechanics of the pain. Non-inflammatory joint pain, like osteoarthritis, is essentially a mechanical wear and tear issue.
Okay.
The cartilage is degrading, so it gets worse with use and feels better with rest.
Like a worn-out tire.
Exactly. But inflammatory arthritis, like rheumatoid arthritis, is driven by immune cells flooding the joint fluid while you sleep.
Oh, wow.
Yeah. So inflammatory pain is notoriously worse in the morning. Patients have this profound stiffness lasting over an hour, and it actually improves as you move around and manually pump that fluid out of the joint.
Ah, so movement physically flushes the joint. That makes perfect sense. And question 4, the extra-articular features. That means looking outside the joints entirely, right?
Right, because if the immune system is malfunctioning, it rarely limits itself to just the knuckles.
It goes everywhere.
It does. A rheumatologist will look at the eyes for uveitis, they'll check the skin for psoriatic plaques, or even ask about gastrointestinal issues. Systemic diseases leave systemic clues.
Which brings us to the very first question on that skeleton, the one that dictates the entire timeline of the investigation. Time. Is it acute or chronic? Let's talk about the clock.
The clock is the ultimate gatekeeper in rheumatology. The definitive cutoff is 6 weeks.
6 weeks.
Yeah. If the joint involvement has been present for less than 6 weeks, it is acute. Anything beyond that crosses the threshold into chronic.
Why 6 weeks? Is there like a biological switch that flips on day 42?
It's less of a biological switch and more of a statistical safety net. The first 6 weeks represent a period of extreme diagnostic danger for the doctor,
Danger how?
because in that early window, an acute presentation could be something entirely benign. Consider a post-viral arthritis, like what happens after a chikungunya infection.
Okay.
The virus triggers massive joint inflammation, but once the immune system clears the viral fragments, the arthritis completely resolves on its own.
So it's essentially collateral damage from a standard immune response. You just write it out.
Exactly. But at the exact opposite end of the spectrum, that same early joint pain could be the terrifying first presentation of systemic lupus erythematosus, or SLE.
Oh, wow.
Yeah, where the immune system has fundamentally broken its own tolerance and is beginning to attack healthy cellular DNA.
So in week 2, a harmless viral hangover and the onset of lupus can look identical to the naked eye.
Often, yes. The disease pattern just hasn't fully declared itself yet. It hasn't reached its mature state.
I always picture it like a Polaroid picture developing.
Oh, I like that.
Yeah, you take the photo, and it's just this blurry gray square.
Yeah.
In the first 2 minutes, you have absolutely no idea if you're looking at a picture of a scary bear charging at you or just a friendly dog running through a field. You just have to wait for the colors to fill in.
That perfectly captures the waiting game, though unlike a photograph, a patient's underlying biology is actively shifting while you wait. Both the doctor and the patient have to sit with that ambiguity, which is honestly agonizing.
I can imagine.
Patience is a required clinical skill here.
But humans hate waiting, especially when they're in pain and terrified that their hands are physically changing shape. Is there a way to cheat time? Like a way to see the Polaroid before it finishes developing?
Today, increasingly, we can. We bypass the clock using advanced biomarkers. We look for the biological breadcrumbs in the blood before the physical joints show the full damage.
Let's dig into the biology of that. What kind of biomarkers are we talking about?
A prime example is anti-citrullinated peptide antibodies, or ACPA, which are heavily tied to rheumatoid arthritis.
Okay, let's translate that for everyone. What exactly is a citrullinated peptide, and why is the body building antibodies against it?
Citrullination is actually a normal biological process. When your body experiences inflammation, certain proteins undergo a structural change. Specifically, an amino acid called arginine gets converted into citrulline.
Okay, so a protein changes shape.
Right. Usually your body cleans this up without issue. But in patients developing rheumatoid arthritis, the immune system suddenly fails to recognize these citrullinated proteins. It views them as dangerous foreign invaders, like a bacteria or a virus.
So the immune system basically flags its own altered proteins as a threat and builds ACPA, these highly specific antibodies, to attack them.
Precisely. And the key here is timing. If a patient presents acutely, say week 3 of joint pain, and their blood shows a massive titer of ACPA, that is a blaring siren.
Oh.
The blood is predicting the future of the joints. It strongly signals this is going to evolve into chronic rheumatoid arthritis well before the physical joint deformities even occur.
That is a phenomenal use of biology to shortcut the clock. But what happens when the blood doesn't give you a clear crystal ball answer, when the labs are just ambiguous?
Well, then doctors have to rely entirely on how the joints visually present themselves over time. This brings us to a highly specific physical pattern.
Topography. Question 5 on our skeleton. Where exactly is the fire burning? Let's paint a picture for you listening. Picture both of your hands, palms facing down on a table. The knuckles at the base of your fingers, where the finger joins the hand, are visibly swollen. Your wrists are puffy too.
Right.
And it is perfectly mirrored. Whatever's inflamed on the left hand is inflamed on the exact same joint on the right hand.
Which tells the clinician the inflammation is symmetrical, driven by systemic circulation, and it is additive, spreading to multiple areas.
Symmetrical and additive. But here's the crazy part. The very last knuckle on your fingers, the tiny distal interphalangeal joint right before your fingernail, is completely untouched. Perfectly normal.
Yes. Symmetrical, additive, and specifically sparing that distal joint.
It's incredibly eerie how precise that is. So it's sort of like a burglar who breaks in and ransacks a whole house, tears up the living room, destroys the kitchen, but meticulously avoids stepping on any of the rugs.
That is a great way to put it.
Why?
Yeah.
Why does the immune system spare that one specific tiny knuckle?
Because of what the immune system is actually targeting. Rheumatoid arthritis isn't an attack on bone. It's an autoimmune attack specifically on the synovium. That's the delicate membrane that lines the joint capsule.
Okay.
The knuckles at the base of your fingers, the wrists, the knees, they have a massive amount of synovial tissue.
They're essentially big, fluid-filled shock absorbers.
Right. But that tiny distal joint near your fingernail, it has very little synovium. It relies more heavily on cartilage and bone structure. Because it lacks the primary target tissue, the RA immune cascade mostly ignores it.
That is fascinating.
And in contrast, mechanical diseases like osteoarthritis, which destroy cartilage, heavily target that exact same distal joint. The spared joint tells you the mechanism of the disease.
The mechanism dictates the pattern. That completely demystifies it. It just shows how much vital information is hiding in plain sight, just waiting to be noticed. Which actually brings us to something referred to in clinical practice as the vault.
Yes, the vault.
And this is a statistic that genuinely alters how you view modern medicine.
It is arguably the most humbling fact in all of musculoskeletal diagnostics.
We've talked about these incredible immunological biomarkers, the citrullination process, the complex rules of joint math, but clinical consensus reveals a staggering reality. Across this entire complex field of medicine, 60 to 80% of the information required for a correct, definitive diagnosis comes from where?
It comes purely from the patient's history, from the conversation between the human being in pain and the clinician listening to them.
Wait, up to 80%?
Yes, up to 80%. Not the advanced labs, not the MRI machines, not the X-rays.
That is wild.
The technology is primarily there to verify what a careful, methodical, attentive conversation with the patient has already revealed. The story contains the map. The labs just verify the coordinates.
Which brings us perfectly back to our mystery patient, the anonymous woman at the triage desk whose file we opened with, "My hands don't look like my hands anymore." We get one final vital clue from her file today based on that exact concept of listening to her story.
We do.
During her conversation with the intern, she admits something crucial. She says this swelling, this terrifying change in her hands, has been going on, quote, longer than I want to admit.
Longer than I want to admit. From a clinical perspective, that single conversational fragment is a massive pivot point for the investigation.
Because of the 6-week clock.
Exactly. Even without giving an exact number of days, longer than I want to admit, tells the clinician that we are almost certainly past that 6-week threshold.
Right, the waiting period is over.
We are no longer waiting for the Polaroid to develop. We are no longer dealing with an acute, self-limiting viral issue like our chikungunya example. This is a chronic, systemic problem.
And just like that, with one conversational clue, we have officially shifted her out of the acute danger zone and dropped her into an entirely different chronic diagnostic universe. The underlying math has completely changed.
The entire differential diagnosis flips based on that one sentence. We rule out the acute benign causes, and we begin hunting in the chronic autoimmune differential. It is the perfect demonstration of how a patient's history drives the science.
So let's trace this incredible journey back for you today. We started with a mystery and learned that joint math, counting 1, 3, or 5 joints, isn't arbitrary. It's a strict sorting hat based on the probability of localized versus systemic biology, pulling you into distinct diagnostic universes like the SPO family with its asymmetric enthesitis-driven pathology.
We also examined the imposters like polymyalgia rheumatica and fibromyalgia and explored the biological mechanisms of how they successfully mimic widespread joint pain without actually inflaming the joints.
We broke down the 5-question skeleton, learning how the morning stiffness of inflammatory pain differs from mechanical wear and tear. We learned about the agonizing 6-week clock and how understanding complex immunology, like the body attacking its own citrullinated proteins, allows us to cheat time.
And we decoded the physical topography, understanding exactly why an autoimmune attack on the synovial lining will spare the tiny joints near your fingertips. But above all of that science, we learned that the most powerful diagnostic tool remains the human conversation.
60 to 80% of the answer is embedded in the patient's story, which leaves me with a lot to think about regarding where medicine is heading.
It absolutely should. And I want to leave you listening with a lingering, provocative question based on that exact statistical reality. If up to 80% of a correct medical diagnosis comes entirely from a doctor just sitting, listening, and taking a nuanced patient history, what happens to our healthcare system as modern medicine becomes completely obsessed with quick technological scans, rigid 10-minute appointment windows, and AI symptom checkers?
Right.
As we gain more and more advanced medical technology, are we ironically at risk of losing the simple conversational art of the diagnosis?
That is a heavy, fascinating question to chew on. Because if we outsource the conversation to algorithms and rush the history, we might just miss the actual person sitting right in front of us, staring at their hands, wondering why they don't look like their own hands anymore. Thank you so much for joining us on this deep dive. Keep questioning the world around you, keep looking for the invisible mechanisms behind the facts, and we'll see you next time.